So today's session, we have George Silverschatz and David Keeley on becoming a more effective therapist. So let me give you a brief discussion, this introduction of the two presenters. George Silverschatz is a clinical professor in the Department of Psychiatry at the University of California, San Francisco School of Medicine. He has been an active psychotherapy researcher for 40 years and is a past president of the Society of Psychotherapy Research. And he has been a leading figure in control mastery theory for many years. And David Keeley is assistant professor at the University of British Columbia and provide teaching and clinical supervision there, as well as research. He has been conducting psychotherapy research on factors that influence psychotherapy process and outcome. And he has been working with George on development of integrative and personalized approaches to treatment. I got to know George's work in 1990s, and one of his early work on case formulation research has probably been most influential in my career as a researcher, because it's such a great integration of clinical and research. And it's such a great pleasure to have them both, because I have been working with David preparing for the Vancouver meeting, which we would like to have in the future. And finally, I'm going to introduce Alex Vaz, who is the chief editor of our newsletter, Integrative Therapist. He's a co-founder and the host of Psychotherapy Expert Talks, not the co-founder, just the founder, which is online in-depth interview series with distinguished clinicians and psychotherapy researchers. They are on YouTube, and you will be you will enjoy very much watching the series. And he has been probably the leading figure in the current research on deliberate practice. And he might be playing some music in the background, but I'm not sure. So I welcome you, George, David, and Alex. Thank you so much. Everyone joining from everywhere in the world.
And I want to also thank George and David for doing this today. I'm also really excited to be part of this. I just wanted to remind all the attendees, just before we start things, that to everyone joining us today, you can write your questions to George or David on the Q&A tab that you have on your dashboard below. So you can open that at any time and write a question that later can be answered by George or David. If you have any kind of technological problems, please do that on the write a question on the chat window. So tech problems, chat, questions for our dear presenters, Q&A tab. And that's all I want to say, because I want to give it up to George and David.
Thank you. Thank you very much, Alex, and thank you, Shigeru, for that wonderful introduction. It's a great pleasure for us to be here, and a particular pleasure to have such a wide international audience. So we're looking forward to our conversation with you. So you should be able to see my slides now, I trust, right? They should be up on the screen. So I'm going to just cover, David and I are going to share some of the time together, and I just want to show you a little bit of what I would like to cover in the first part of this talk. So I want to make the point that a personalized approach is really essential for what I consider effective psychotherapy. And that control mastery theory, which I'll be telling you more about, provides a very useful trans-theoretical model for such an approach. In other words, control mastery theory is not some new brand of therapy that I'm prescribing or trying to advocate. As you'll see in a moment, it's a much broader model for understanding psychotherapy. I'm going to talk a little bit about the essential building blocks of control mastery theory, because I want to try as much as I can to give you an intuitive feel for how this particular theory emerged. And then I want to show you how these building blocks have led to a case formulation method that we think can make therapists more effective. So I'm going to begin with a really, really simple question that Joe Weiss raised. He's one of the founders of control mastery theory in 1952. A very simple question, which is, why do we cry at the happy ending of a movie? What is that all about? Why do we do that? And the answer that Weiss proposed was something like this, that at the happy ending of the movie, it's actually safe for us to experience the grief and sadness that we might have been feeling earlier during the sad parts of the movie. And so at the happy ending, we can allow ourselves to feel that kind of sadness that may have been more difficult to feel during the sadder parts of the movie. So this particular paper, this is a very short paper. It's a one-page paper written in 1952. But this paper was the cornerstone, I would say, for the development of control mastery theory. And it led to many, many important insights and clinical applications. So for example, it answers questions like, why do we have pleasant dreams during periods of extreme stress, and frightening dreams when the stress has passed? What's that about? Well, it's similar to the crying at the happy ending of the movie, that during periods of stress, we have pleasant dreams as a way of being able to maintain our equanimity. And when the stress has passed, we can allow ourselves to feel the anxiety or the stress or the danger that we may have been warding off. And similarly for psychotherapy, what are the conditions that allow patients to lift their defenses and bring up painful feelings? And again, it's a similar kind of thing, that during the when patients feel safe in the therapy, that's what allows them to lift their defenses and to be able to confront painful feelings. Now, I want to give you a very brief clinical example of how this concept helped me a great deal a few years ago in a case that I was supervising in psychotherapy. The case was an exceptionally painful and difficult case. I'm glad I wasn't the therapist. I was supervising this case, and the case was something like this. This was a woman in her, 50s, who had two daughters, and her daughters had been sexually abused by their father for many years. And the daughters had become, as you might imagine, was a very, very obviously a traumatic experience. And these daughters both became very, very ill. One of them was psychotic. The other one was a drug addict and a sex worker, and a very, very tragic case. This woman had been in therapy before with a therapist, and in her previous therapy, the therapist focused almost entirely on the nature of this abuse and her feelings that she should have done more and could have done more, and her responsibility for it and so on. And the patient just kept getting worse and worse, although she kept talking about it, but she felt like she didn't really have a right to live and so on. She ultimately left that therapy, and within a couple of months, she started therapy with the person that was consulting with me. So the person consulting with me started in the same way. He started by focusing a great deal on this history, this very traumatic history, and again, the patient was not doing well with it. And I just encouraged the therapist to just stop asking about this material and to just see where the patient might go if he were not showing so much interest in it. And sure enough, she started talking about issues at work and people at work and relationship and a man at work who was interested in her. And then that's all and we heard no more about this history of abuse. This went on for quite some time. She gradually started to reveal that this nice man that she had met at work was very interested in her and was very kind and warm and supportive. And anyway, to make a long story short, they became engaged and she got married, and you know, they had a pretty good wedding and a honeymoon, and the patient seemed very, very happy. And then after a couple of months of being married, she returned to talking about this very traumatic history. But the difference was that she was now coming at it from a place of safety. In other words, because she had a relationship in which she felt supported and loved, she was able to deal with this horrific kind of traumatic history in a much more contained and helpful way. So this was an example of a clinical application, if you will, of this phenomena of crying at the happy ending, which I think helped this therapist and helped me understand this process a great deal. Okay, so I'd like you to think about a very brief clinical vignette that I'm going to show you, and we're going to come back to the vignette in a few minutes after I've given you a few points about control mastery theory to see how we might be able to understand it. So this is of a patient who is 30 years old, a 30-year-old married woman who sought psychoanalysis because she fights incessantly with her husband. She loves her husband. She loves her husband a great deal, and she's mystified about why she fights with him. She can't enjoy a sexual relationship with him and so on. And that's why she sought out psychoanalytic treatment. So this is the vignette I want you to think about. And again, we're going to come back to this in a few minutes. This is about the 5th hour of the therapy. And the patient starts out the hour in the following way. I had an interesting dream last night, and there's a pause. I also had an upsetting fight with my husband, and now there's a long pause. Which would you like me to talk about? Okay, so just think about this vignette a little bit, and we're going to come back to it. Okay, so this is the essence of the control mastery theory that I'm going to try to give you a very quick whirlwind tour of this model. So first of all, it's not, like I said earlier, it's not a brand of therapy. It's not a prescribed set of techniques. It's a model. It's an integrated model about how the mind works, about how psychopathology develops, and about how psychotherapy works. And it's a model that can be applied trans-theoretically. We don't privilege one particular technique over another. So these are the basic building blocks of the theory, okay? And what I would propose to you is that with these building blocks I'm going to go over, you would arrive at this theory that I'm talking about. So the first one is adaptation, that people are adapted to their environment and their reality. Safety and dangers, I've already alluded to, is a critical component of this theory. The role of trauma and adverse experiences in the development of psychopathology, that certain kind of schemas and pathogenic beliefs often develop from these kinds of traumas, that patients are motivated to test these pathogenic beliefs, and that in response to tests, when they're responded to positively, people have corrective experiences, and those experiences help them a great deal. So starting with adaptation, which is an important element of this theory, the cornerstone. This comes directly from Darwinian biology, what Darwin called an adaptive imperative. In other words, we're hardwired by evolution to, all living things are hardwired by evolution to adapt to their environment. That's what evolution does for us. And adaptation is really the foundation of the control mastery theory. In a certain way, as you'll see, everything rests on the concept of adaptation. So a few basic points about human adaptation. So in humans, key to adaptation is forming a conception of reality. In other words, our beliefs or our schemas that we hold is key to adapting to our reality. And a reliable model of reality has to be guided by learning very quickly about what kinds of conditions are safe and what kinds of conditions are dangerous. So for example, evolution wires a little fish to stay away from big fish. And evolution privileges danger, of course, because if the little fish decides they want to go play with the big fish and the big fish is hungry, that would be game over for the little fish. So safety and danger are critical in terms of adaptation. And in humans, as well as, of course, in many animals, the primary forum for developing our conceptions of safety and danger is our relationships with parents or caregivers. That's who we rely on for developing our models of safety and danger. Now, when we get to psychopathology, we have to remember that what was once adaptive can become pathogenic, and what is currently pathogenic was once adaptive. So take a simple example of a child who grows up in a family where they're treated badly, or it's a very dysfunctional family. It can be very adaptive for the child to think that there is something wrong with them, rather than to think that there's something wrong with the parents or the family. And that can be adaptive for a child, but later on, that is going to become pathogenic and problematic. Or a simpler example would be a child who grows up with a very depressive parent. The child can sacrifice a great deal in order to take care of that depressed or needy parent. And again, that would be adaptive for the child to do that because the child needs their parent. But later on in life, you can see how it would become pathogenic very, very easily. So this is the model of psychopathology in a very, to put it very, very concisely, that we have adverse experiences or traumatic experiences that based on those experiences, we develop pathogenic schemas, or what Bowlby called internal working models. And when I talk about a pathogenic belief or a pathogenic schema, I'm not talking about some simple, narrow cognition. It's a schema that includes beliefs, it includes emotions, it includes behaviors, it includes relationships. It's an integrated kind of system, the way schemas typically are. Okay, so that we've covered quickly the model of psychopathology. Let's go to the model of the theory of therapy. So these are the key elements. Patients come to therapy in order to disconfirm pathogenic beliefs and master problems. In other words, patients come to therapy in order to get better, okay? And the theory holds that patients have a plan for doing so. Now, the plan concept is really much simpler than it sounds, because the plan, when we talk about the patient having a plan, what we're talking about is to disconfirm, when they come to therapy, their plan is to disconfirm their pathogenic beliefs and schemas. That's what their plan is. And basically, you can see that's kind of the mastery mode. Many models of psychotherapy have this kind of mastery motive, and this is the mastery motive in control mastery theory. Okay, so when we talk about a formulation of a plan, and Dave is going to cover this in much greater detail, I'm just going to give you a couple of highlights here. We have a kind of heuristic method, if you will, of kind of triangulating on a patient's, on a formulation of the plan. But we focus on these key elements when we try to arrive at a formulation. We talk about the patient's adaptive goals in coming to therapy. In other words, what do they want? And that can be conscious as well as unconscious. What are the obstructions to achieving those goals? In other words, what's getting in the way of the patient achieving those goals? And those, of course, are the pathogenic schemas that are getting in the way of goals. And then we want to think about what gave rise to those pathogens. We don't just come into the world with pathogenic schemas. So we want to identify the traumatic or adverse experiences that gave rise to these pathogenic schemas. And then we want to think about patients' tests. How are patients going to test these pathogenic schemas in the therapy or in life generally? And then finally, what kinds of new experiences or insights are going to help them disconfirm those pathogenic schemas? So these are the elements of when we talk about a individualized case formulation that will help you do more effective therapy. These are the elements that we pay attention to: the patient's goals, the pathogenic beliefs or schemas, the traumatic or adverse experiences that created those, and how the patient will test the therapy, and the kinds of new experiences or insights that could be helpful to the patient. Okay, now let's come back to this particular vignette and see how we can apply this, even coming up with a rudimentary formulation. So this is the fifth hour of a therapy. We know a couple of things about the patient. I'm going to tell you a little bit more about the history that she already revealed to the therapist in a moment, but we know one thing from the get-go. We know that the patient is interested. She's coming to therapy because she wants to know why she fights with her husband. She's very interested in that. But she also knows something else. She knows that this is a psychoanalyst, and she knows that psychoanalysts are interested in dreams. So, I had an interesting dream last night. I also had an upsetting fight with my husband. Which would you like me to talk about? So, let's try to come up with a rudimentary plan formulation of this case. So now I'm going to tell you some things that the patient told the analyst in the prior sessions before this fifth session. A key thing that she told the analyst was that she had an exquisitely narcissistic father. And she gave examples of just how narcissistic he was. So when the father was going to take her and her siblings to the park, for example, he would be very pleased if they all wore matching clothing or if they wore clothing that he wanted them to wear. But if any of the children chose clothing that they wanted to wear, he would get very upset and downcast and sullen and so on. So a very narcissistic father. Now, what kind of internal working model or what kind of schema would a person develop in growing up with a father like that? Well, the simple schema is, I need to subjugate myself to someone else's preferences or wishes in order to preserve a relationship with that person. That is a quintessential pathogenic schema. And as I was saying before about adaptation, you can imagine how someone growing up with a narcissistic father like that, it is adaptive to actually do that and see that, but it will cause her problems later. And the kind of problems it causes her is it makes it very hard for her now, for example, to get along with her husband. She always has to fight with him because she doesn't want to feel like she's subjugating herself to him. And that's what part of the fighting is about. In terms of tests that she might pose for the therapist, the main test in this is, I had an interesting dream last night. I had a fight with my husband. Which would you like me to talk about? You can view that through the lens of testing of, will I need to subjugate myself here in the way that I had to growing up? Will you need me to subjugate myself the way my father needed me to subjugate myself to him? So that's the test in that little vignette. Okay, now we come to the crux of the matter. What would an effective therapist say? What would you say, knowing these things that I just highlighted, right? What would you say to the patient? Well, it's obvious. This is not rocket science, right? You would say, I mean, among the helpful things you could say, I think it's important that you talk about whatever is most important to you. Now, that would disconfirm this pathogenic schema. It would pass this test that she has, and so on, right? Now, a lot of you might say, well, of course. I mean, wouldn't you want to, you could say that to anyone and it would be helpful. And the answer is no, that's not true. Because technique, from our point of view, technique cannot guide effectiveness. Why do I say that? Because for another patient, this exact same intervention would actually be detrimental to her. So here's an example of a real patient, a patient who grew up, also a woman in her early 30s, came to therapy. She grew up in a family of parents who were completely dysfunctional. They were both alcoholic. They were completely self-absorbed, and they were always overwhelmed by having a child. So when she was growing up and would ask the kind of appropriate questions of a parent that a child would ask, a typical reaction from her parents would be, we don't know what to do. Why don't you figure it out? You do what you want to do, and so on. Now, for that patient, if she hears the therapist say, patient comes in and says, I'm not really sure what to talk about. What do you suggest, or what would be most helpful? And the therapist says, talk about whatever is important to you. That would not be quite so helpful for that patient. And in fact, it could actually be detrimental to her, because the patient experiences what they hear through the lens of their earlier adverse experiences, through their pathogenic schema, and so on. And through that lens, this patient would hear that as, you figure it out on your own. Okay? So that's, in a nutshell, about how to use the formulation to be more effective. And Dave is now going to talk about that in a whole lot more detail.
Thanks, George. That was great. I'm just going to get set up here to share my screen.
Sure.
All right. Can everyone see this, the slides?
Yeah.
Yes.
Great, great. George, feel free to jump in at any point here if you have anything to add.
Sure.
Okay, so I'm going to go through the plan formulation in a little bit more detail and go through the different components that we think about when we're developing an individualized case formulation regarding a patient's plan for therapy. And before I begin, I have to go through some disclosures here. I'll just put this up on the screen there. So my main role is at UBC, where I'm an assistant prof. I also do some private practice work. I have some research funding that I don't think presents any conflict with regard to what I'm presenting today. And I take an integrative approach to psychotherapy that leans kind of psychodynamically. And that's one reason why I really like control mastery theory and the plan formulation method, because it doesn't privilege one particular technique and instead focuses on how can we integrate different approaches in order to develop kind of responsiveness that really meets the individual where they need to be met. And so before I begin talking about the plan formulation, I know this is a very practical and applied session today, so I don't want to get into a lot of research, but I just want to point out that one of the advantages of the plan formulation approach is that it has pretty good empirical support. And I know this research, it's very difficult to conduct, and it's very rigorous work. But I just want to throw that up there on the screen there so that people can see that there is literature on this that demonstrates that we can make these plan formulations reliably, and that when therapists respond to patients in ways that are compatible with a plan formulation, those patients make immediate progress in therapy. And that's been measured in different ways, but we can see that when a therapist is compatible with the plan, whether they are operating from a control mastery theory perspective themselves or not, it's the plan compatibility of their intervention that is predictive of the patient's progress. And that can be seen within a session. But also, there's some evidence here that George presented a few years ago that shows that therapist plan compatibility, it tends to be associated with improvement over the course of treatment. So patients have lower distress and greater goal achievement to the extent that their therapist is compatible with the plan formulation. I like to think about plan formulation as a clinical skill. There's been a lot of discussion lately in the psychotherapy world about therapist skills. We're getting more focused on therapist effects in psychotherapy and psychotherapy research, with some really exciting, interesting work being done. People like Tim Anderson with facilitative interpersonal skills. The work that Alex has been doing with colleagues on deliberate practice and the importance of therapists practicing their clinical skills. I think about formulation as being a clinical skill, and in particular, the ability to develop clinical inferences as being an important therapist skill that we can practice and that we can refine, and that is really important for being individualized and personalized in our responses to therapy, to patients. Associated with these formulation skills are abilities that have to do with looking beyond what's presented at face value, paying attention to contradictory information that we hear often in psychotherapy, and the ability to generate hypotheses and then test them out and observe them in the patient's responses to us, and being prepared to reject hypotheses in accordance with the evidence that we're presented with, rather than sort of hammering home on a tried and tested technique that sort of is handed down from on high within the literature. I think this approach really encourages us to be very empirical in an experience near way with our patients and really observe how our patients are responding to us. And that helps us hone our own responsiveness to the patient. So here are the components of the plan, and there's a nice little phrase here, got it. So that helps people to remember the different components, and I'll just walk through them. So we've got goals, which are the patient's adaptive developmental goals, obstructions to those goals, which are the barriers to the patient achieving them, and what we're really talking about here today are pathogenic beliefs, the traumas that gave rise to these obstructions of pathogenic beliefs. So that's the got portion. And so when I teach this, I suggest that the got part is sort of what the patient brings. This is what the patients bring to therapy. It's what the patient's got. And then the it is what they're needing and what they're looking for and how they're going to work in therapy. So the it part is comprised of insights and experiences. So these are the insights or the knowledge and the experiences that the patient will need in therapy or will use to try to overcome their obstructions or pathogenic beliefs, to master their traumas, and to achieve their goals. And finally, tests. These are the ways in which the patient might test in therapy, which is a particular way of working to feel safe in order to become more aware of their goals, more aware of what's holding them back, and to work on disconfirming their pathogenic beliefs that are getting in their way. So I'm going to go through each of these components in a little bit more detail. Before I do, I want to just draw your attention to the idea that even though I'm proceeding sequentially through each component, it's important to recognize that when we're actively formulating a case, we're not necessarily doing that in real time. We can sort of begin, and in practice we do begin to develop inferences almost at any part of the formulation. So we can begin with inferences about a patient's goals, or about their traumas, or about their pathogenic beliefs. And as we get more information from the patient, we consider each of these components and we put it together in an iterative way, right? So that as we get more information about a patient's pathogenic beliefs, it helps refine our sense of what the patient is trying to overcome. And as we get more information about a patient's traumas, it also helps to refine our understanding of the kind of pathogenic beliefs that emerged from those traumatic experiences. Now, patients often reveal information idiosyncratically. There are a lot of individual differences in how patients present information in therapy. Some patients will come in and just lay it all out there for us right away, and other patients need, a little bit more help opening up, a little bit more probing, more questioning. So we try to work with that when we develop a formulation, and we can begin formulating and developing clinical inferences even with very limited information. Having said that, however, it's useful to invite the patient to provide some history and to tell us about their problems and their goals, where they're at right now and where they see themselves going, what is it that they're wanting, and to try to get a developmental history and get a sense of what things were like for them in their childhood, with their family, growing up, with peers, a significant relationship history. So we can really get as full a picture of the patient as possible early on. That helps us with our formulation. Now, of course, some patients are not able to do that as readily, and for whatever reason they can't or won't provide a comprehensive history. And that in itself may be something worth considering in developing some inferences about. Does the fact that the patient struggles to give a coherent history, does that reflect some kind of pathogenic belief? Can we make some tentative inferences about that? Maybe there's some sort of trauma that the patient doesn't feel safe enough talking about. And so the not telling, in a way, can be thought of as a sort of tell, if you will, and give us something to go on and develop at least some tentative hypotheses about it. So when we think about the patient's goals, we're thinking about this in a broad way. What are the patient's developmental goals? We definitely want to take note of what the patient brings in as their stated goal for therapy, but we don't necessarily want to take that at face value in all cases. We want to be thinking, are these goals adaptive and healthy given where the patient is at in their own development and in terms of their life circumstances and their abilities? So we're trying to think more broadly about where the patient is trying to go in life and what are they working on developmentally, what are they needing to overcome and to accomplish. So it's conceivable that someone could state a goal that's incompatible with their true objectives. So a patient, for example, who was traumatized by parents who really pushed them very hard as a kid and who was always grilling them about, you never do enough and you're constantly slacking, and the patient comes in and presents the goal of, you know, I really want to stop procrastinating. I find myself taking things too easy and not working hard enough, and I think it's causing me problems. We would definitely want to evaluate that and consider what the patient has to say about the kinds of problems that they perceive to be related to this issue. But it may be that the patient's stated goal of wanting to procrastinate less is not actually what they're trying to work on developmentally. They may actually be trying to work on, how can I feel more relaxed? How can I take a more relaxed pace and see myself as a person who is worthy and has a good sense of self-esteem and work ethic without being worked to the bone and driven incessantly so much. And so that may be more of what the patient's trying to do. And that's part of why we want to get a good history and really listen to the whole story that the patient brings in, so we can consider whether their stated goal is actually what they're wanting to work on in therapy, whether it's adaptive and developmentally healthy, or whether it may actually reflect a pathogenic belief. So another example would be a patient, one patient that I saw a while ago came in with the goal of, I want to stop sabotaging my relationships. It seems like whenever I meet a guy that I like, I end up complaining too much and carrying on and really ruining the relationship. And now I'm with this guy that I think is great and I'm really enjoying the relationship, but you know, I find myself picking on these things that bother me and complaining about them, and I worry that I'm just going to chase him away with all of my negativity. Now, upon getting further history from the patient, we learned that, in fact, this guy that she claims is so wonderful treats her very poorly. He's very demeaning to her. She actually suspects he might be having an affair with somebody else. She's always deferring to his demands. He never shows up on time. He's very unreliable and narcissistic. Turns out she also had a very narcissistic and difficult to please father. So she always felt like she was in the wrong because she couldn't please her father, and she's always ruining things when she complains about some need of hers that goes unmet. So actually, the inferred goal for this patient was not that she wants to learn how to stop sabotaging her relationships, but that what she really is trying to work on is to have improved self-esteem and to feel more deserving of being treated well in relationships, and more deserving of a partner who's healthy and who can treat her well and who can respond appropriately to her. So that's what became the actual therapeutic goal that we were working toward. Sometimes a goal might be relatively vague and even legitimately a symptom-focused kind of goal that is, on the face of it, less an expression of a pathogenic belief. And so but we still want to try to understand more and think about whether this goal itself might conceal a more adaptive goal, or whether it's reflective of a response to the patient's impediment in achieving important developmental goals. So a patient might say, I want to overcome my depression, which of course is a very reasonable and very common goal that patients bring to therapy. But depression means different things to different people, and we would want to explore this further and get a sense of what that's about for this patient. So, for example, a patient may feel that she's not entitled to experiencing and expressing negative feelings. She may have been traumatized by parents who said to her, "You've got nothing to cry about. You have nothing to be upset about. What are you getting so upset over?" And that would lead to a pathogenic belief that she doesn't deserve to really feel her feelings, that she's not entitled to having any complaints. And her depressive symptoms may be reflective of that to some extent. And so if we were to jump in and right off the bat assume that her goal is simply to eradicate these depressive symptoms, we may not be doing enough to help her disconfirm that pathogenic belief. And a patient like that may need more help accepting that she has legitimate negative feelings, and that these ought to be thought about, and that these can be reflected upon, and that people can respond to them. For another patient, however, those depressive symptoms may reflect some degree of hopelessness, some degree of despair that important developmental goals are not being achieved. And we would need to learn more about the pathogenic beliefs that are interfering with their pursuit of important goals. So in control mastery theory, as George mentioned, we assume that patients want to work in therapy, they want to achieve their goals, but due to earlier adaptations, they've been obstructed or conflicted in doing so. So we can think about why a patient may not state their true goals as having to do with this principle of safety and danger. It may not be safe enough for someone to state what they're truly wanting in life or in therapy. This may be considered to be threatening to somebody. It may be an expression in the patient's mind of disloyalty to a family member. The patient may feel guilty obtaining help, for example. Even the awareness of a goal, let alone the statement of the goal to a therapist, might be threatening to the patient. So for example, a patient who has a goal of wanting to feel more alive and more vibrant might feel that that's endangering to one's family members if their relationships with important figures were characterized by people being very sort of deadened and lacking vitality. They could feel some degree of survivor guilt or surpassing guilt if they were to allow themselves to be aware of this goal, that they want to actually get away from that they want to feel more alive and vital and live a richer and fuller life. That would help explain why some patients may not immediately reveal what it is that they're wanting to work on, and why they may need to feel safe with the therapist and may need to test the therapist before some of those goals may be revealed. Nevertheless, we can try to infer some of those goals after learning more about the patient's history, pathogenic beliefs, and traumas. So moving on to the second component, obstructions, we think about what's getting in the way of the patient achieving his or her important developmental goals. Now, of course, there are many external barriers that could be serving as an obstruction to the patient trying to move ahead in life. Factors such as poverty, oppression, and I don't want to minimize these in any way. It's very important to take these into account. But for our purposes for today and for the purpose of fleshing out the plan formulation, we're going to focus on obstructions at the level of the individual psychology with an emphasis on the patient's pathogenic beliefs. So just quickly to review, as George mentioned, these really are more like schemas. They're internal working models or mental representations of how the patient ought to be in the world. Rather than just a simple belief. And there's a lot of overlap and consistency, I think, with other models or languages that talk about mental representations or schemas or internal working models. And this may be one of those issues upon which therapists of different persuasions might find agreement that this is a core aspect of the difficulties that patients bring to therapy. So as George mentioned, these beliefs help children adapt to experiences and environments, to get along with others, and to understand how to behave and experience oneself and one's relationships with others. And keeping in mind that these beliefs are developed usually during a phase of life when the child doesn't have the benefit of broader perspective, of critical thinking abilities, or broader knowledge of the world. So that influences the degree to which the child may, personalize the experience and blame themselves, if you will, for many of the problems that they experience in their environment. So as George mentioned, pathogenic beliefs, they help the child to adapt to their environment, to avoid further trauma, to maintain good relationships with important people in their lives. They often represent a compliance or an identification with the attitudes and behaviors of a traumatizing figure. It's much safer for a child, if they're being maltreated, to see themselves as the reason for that. It's a bit more of a hopeful position to be into, because they may feel very powerless. They would, in fact, be very powerless to change the behavior of a parent who's maltreating them. But they may hold on to some hope that if I'm the source of the problem, if I'm being maltreated because I'm bad, because I deserve bad treatment, then maybe there's some hopefulness about, maybe if I work on myself in some way or do things differently, I may be able to get myself out of it. Or identifying with a parent. Not identifying with a parent might be very endangering to a child. So it's very safe to mimic a parent's behavior or attitude in a way, in order to remain close and connected to a parent. It's important to recognize that these beliefs are very powerful and pervasive, and they serve as a guide to how one should be in the world. But this guide, by the time patients come to us, is not adaptive any longer. It's very unhelpful to the patient, and it's getting in their way. One of the ways in which we try to think about pathogenic beliefs is in a kind of if-then format. So often these beliefs serve as a kind of imperative to the patient. So for example, if I'm independent, my family will be abandoned. Or if I let others get to know me, they will surely reject me. Or if I don't take care of someone's every need, even at my own expense, then they will suffer. And what that means is that I'll be a bad person. So there's this if-then quality to a lot of pathogenic beliefs. These beliefs obstruct patients in tangible, negative ways. They prevent them from pursuing and attaining important goals. And I just wanted to include this slide. These are some randomly selected examples from case formulations from the San Francisco Psychotherapy Research Group. They give an example of the kinds of pathogenic beliefs that can be formulated from patients' material early in therapy. So I won't go through all of them, but for example, I'm fundamentally unlovable. That's a frequently encountered goal among patients. I deserve to be mistreated. Separating from parents or loved ones would be hurtful, disloyal, or abandoning. My feelings, needs, or behaviors are overwhelming or alienating to others. Now, how do we infer these pathogenic beliefs? Well, sometimes they may be relatively clear and easy to identify, but often it's something that we have to read between the lines to pick up on. And we can do this by paying attention to contradictory information that a patient may present to us. So for example, a patient may describe themselves as being unintelligent, and they're not able to accomplish anything academically or professionally, and they feel like they're just stuck, and they're not destined for any kind of satisfaction in their academic or vocational life. But at a different point in the interview, they actually give evidence of having achieved really well on an exam that they barely had to study for. And so that would alert the therapist to the fact that there's some contradiction here. The patient's presenting themselves in a particular way, stating their problem in a particular way, but then there's also some evidence that this is maybe not quite the picture that they're describing. And so that could give us a clue that maybe the patient feeling stuck isn't really to do with them being unintelligent, but that sense of themselves as being unintelligent or unable or inadequate in some way. That's getting more at the pathogenic belief that we could develop some inferences about. So another example might be a patient who describes a history of self-sacrifice, self-deprivation, inordinate deference to others. We would develop some inferences about that the patient believes that she doesn't deserve her own needs being attended to. And we get further history as we get to know the patient more that can then flesh this out and clarify for us. And this particular patient believed she had to sacrifice her own needs to look after younger siblings. Otherwise, she felt that her alcoholic parents would be overwhelmed and the siblings wouldn't be looked after. So sometimes these beliefs, as I said, need to be picked up on by reading between the lines, looking for contradictions between what the patient describes of themselves, their abilities, their descriptions of relationships with other people, and also in their interaction with the therapist. So a patient may describe themselves as having great difficulties getting along with others, for example, but they seem very polite and friendly and articulate with the therapist. That would alert the therapist that there's to the fact that there's something contradictory here, and that their presentation of themselves as being, unable and ineffective interpersonally, that may not be the full story, and we might be able to infer some pathogenic beliefs about that. I won't dwell on the issue of traumas too much because George covered this already, but just to reiterate that we think about traumas pretty broadly. These are the experiences that lead to the development of pathogenic beliefs. For the purposes of plan formulation, we're not necessarily just talking about some sort of catastrophic event. We're talking about any kind of experience that could interrupt one's safety to pursue important developmental goals. So it could be catastrophic events, but often often traumas take the form of chronic patterns of misattunement. Sometimes it's an attitude in a parent, for example, that just is not a good fit for the child, that creates a traumatic experience in some way, that interrupts the child's sense of being able to be their true self and to grow in the way that he or she needs to in order to achieve important developmental goals. Now, often patients will directly describe a trauma, and it can be very clear to us that this was problematic for the patient during their development. But sometimes these could just be hinted at in what I would call a sort of tip of the iceberg statement, where the patient may present a kind of vignette about a family member that they almost do it in a sort of casual way, or in a way that minimizes the traumatic impact of the event, presumably because it's not safe enough for them to really be in touch with just how traumatic it was. But that's a bit of a tip off to the therapist that there could be some trauma there that we would want to try to develop a better understanding of, and maybe develop some inferences about with respect to the development of pathogenic beliefs. And of course, it's helpful to have an understanding of developmental processes when we're viewing the patient's history to see, to what extent does the patient's description of their own development map on to our understanding of what's important for people at particular developmental stages and phases. When we think about traumas too, we also need to consider what kinds of mitigating factors could have prevented a trauma from leading to a pathogenic belief. So not every traumatic experience, in our view, would necessarily lead to a pathogenic belief that impedes a patient's goal development. And there may be some mitigating factor there, perhaps an important relationship that the patient had with somebody in their development that helps prevent the development of a pathogenic belief. Or it may be simply the patient's own personality and some kind of inner resilience or the patient's meaning making around the event that helps prevent that particular experience from sort of emerging as a pathogenic belief. So I'm going to move on to talk about the it part of the formulation, the insights and experiences and the testing components. When we think about insights and experiences, we think about what kinds of knowledge will help the patient to achieve their goals. So that's very broad. What is it that the patient needs to learn about in order to feel safer, in order to disconfirm pathogenic beliefs, and to work toward achieving their goals? And so this could consist of insight about the content of the pathogenic beliefs, the nature of the beliefs, how the beliefs originated and emerged in the patient's life, what kinds of traumas gave rise to these pathogenic beliefs, and how the pathogenic beliefs help the patient to adapt and the kind of function that the belief served for the patient during their development. And so this would entail thinking about with the patient how the insight, how the pathogenic belief may reflect a kind of compliance with the way they were treated, or an identification with a parent's attitude, for example, or a parent's behavior. And through helping patients develop understanding of their pathogenic beliefs, we can help them to feel less endangered in working to reduce them or relinquish them. And the insight itself may be helpful in reducing the power of the pathogenic belief over the sort of hold that it has over a patient in their life, in the patient's pursuit of important goals. So now these insights may need to be acquired in various ways and worked on or worked through over time, and they can be very pervasive, and so they need a lot of work. You know, I was talking with a patient today who really feels overly responsible for other people. Her pathogenic belief is that she has to take care of other people, particularly men, and in particular weak men, and she has to support them and prop them up. And she's been making a tremendous progress on reducing the hold that pathogenic belief has over her, and she's been able to pursue better relationships with men. But nevertheless, this belief still crops up, and it's still something that we're working through and talking about, and the insight is helping her to shake it off so that it's less overwhelming and influential. But we also think about experiences that the patient needs in therapy. And in this particular example, I think this patient has benefited from having an experience in the therapy relationship where she doesn't have to feel responsible for me. She doesn't have to worry about what I'm thinking or feeling, and I don't think there's anything special I'm doing to create that. That's sort of like the setup of the therapy relationship, if you will, that it sort of comes with the therapeutic frame. But that in itself may be a factor that's helping this particular patient. So when we think about corrective experiences that help disconfirm pathogenic beliefs, we're thinking about real experiences, attitudes from the therapist, behaviors of the therapist. This is really consistent with the notion of corrective emotional experience. However, it's important to recognize that this is individually tailored, and in our formulation, we try to think of what specific experiences would help this particular patient to feel safe, to address pathogenic beliefs, and to master their particular traumas. Keeping in mind that an intervention or experience that's helpful for one patient will not necessarily be helpful for another. So we think about, how will it land on this particular patient? It may be helpful for someone, and it may be unhelpful for this particular patient. And these experiences are inclusive of the therapist's attitude. Control mastery theory has, I think, a unique perspective on this, that some patients may benefit mainly from the therapist's attitude being an important contrast to the patient's pathogenic beliefs and traumatic experiences. So for example, this patient who's driven to work himself to the bone and incessantly overwork himself, he may benefit from the therapist's relatively relaxed way of conducting the therapy. So we would conjecture that this patient would be observing the therapist to see how does this therapist feel? Does he feel like he has to work himself hard all the time? What kind of attitude is he going to take to his work? But I want to spend a bit of time talking about testing. So this is the last part of the formulation where we consider how the patient might use testing in therapy. Now, tests are trial actions by the patient that the patient uses to try to feel safe with the therapist and to try to disconfirm their pathogenic beliefs. So the patient will directly test and then observe the therapist to see if the therapist's response confirms or disconfirms a pathogenic belief. If the therapist's response disconfirms a pathogenic belief, that helps the patient feel safer and more able to make progress. Now, there are two kinds of tests. One is called a transference test, where the patient investigates a pathogenic belief and a traumatic relationship by placing the therapist in the role of a traumatizing figure. In essence, the patient invites the therapist to respond and hopes that the therapist doesn't repeat the traumatizing behavior that led to the development of a pathogenic belief. And so when the therapist passes a test like this, it helps the patient see that they didn't deserve the trauma, that they didn't necessarily, that the belief that stemmed from the trauma may have been adaptive then, but it's not adaptive any longer, and it may be hence safe to address the pathogenic beliefs that are associated with that traumatic experience. So an example would be a patient who feels unworthy and has the belief that they don't deserve to be cared for, would propose reducing the frequency of therapy sessions. Or they may even propose that, you know, you've been really helpful, but I think I want to stop coming to therapy. And a therapist could respond by saying, well, sure, that works. We could meet once a month instead of once every 2 weeks. And if that's the knee-jerk response, that would constitute a failed test for this patient. But if the therapist were to say, well, let's explore it further. You know, I have some reservations about it. I'd like to hear more about what you think about it. You know, we've been doing really good work. I'm not so sure it's a great idea to reduce the frequency of our meetings. That could be passing the test because it would show the patient that the therapist doesn't actually believe that the patient doesn't deserve to be cared for, or that the patient's unworthy or uninteresting. Or the patient who believes that she should always defer to and never challenge others might say, you know, I really had a negative reaction to what you said last week to the therapist. And if the therapist gave a more technique or theory-driven approach, the therapist might say, well, that's your defense mechanisms in action. And that would be a failed test. But if the therapist said, oh, you know, I'm really interested to hear more about it. Can you tell me more? I might have missed something there, or maybe I got it wrong with you. And I'd really like for us to spend some time thinking about it together. That would show the patient that she doesn't necessarily always have to defer to and avoid challenging other people. Different kind of test is called passive into active. And I wish we had more time to go through this in detail because this is a bit more of a complex situation. This is where the patient is positioning the therapist in the patient's role in the context of an earlier trauma in order that the patient can rework the traumatic experience and disconfirm pathogenic beliefs that were tied to it. So in other words, the patient is treating the therapist as the patient was once treated in some attenuated manner. Parenthetically, it's sort of phenomenologically similar to projective identification for those familiar with that psychoanalytic term. And often passive into active tests evoke some strong feelings in the therapist that may perhaps take shape over time. Essentially what the patient's doing in turning passive into active is hoping that the therapist is not traumatized in order to identify with the therapist's resilience and to develop a different relationship to the traumatic experience and to work on disconfirming the pathogenic belief. So an example of this would be the patient who believes that she's responsible for the feelings and behaviors of others might persistently and vaguely criticize the therapist for not doing enough to help the patient and evoke feelings of guilt in the patient for not doing enough. And if the therapist were to become overly guilt-ridden and go out of their way to be overly accommodating and really feel that they're doing something wrong and that they ought to, move heaven and earth to try to accommodate the patient, maybe I should see the patient, 7 days a week and see them on the weekend and take phone calls from the patient during my vacation and so on. That would probably be a failed test for this patient. And what might constitute a pass test would be the therapist who can remain responsive to the patient while also being confident that his or her approach is sufficient, right? And that the patient is actually responsible for her own feelings and behaviors. The tests that I've been talking about have to do with patients complying with the pathogenic belief and then observing the therapist to see whether doing so is necessary. But sometimes a patient may not comply with the pathogenic belief when they're testing. So a patient might behave in a very bold manner with the therapist to disprove a pathogenic belief that she should be meek and subjugating herself. Or a patient might praise the therapist to disprove the belief that one should not enjoy praise in order to evaluate, is the therapist able to feel deserving of praise and able to feel like he or she can enjoy being praised or admired. When patients' tests have been passed, they tend to feel safer, more relaxed, less defended. They may reveal new material, engage in deeper affective experience, developing new insights, or, and this is where it could get a bit confusing, they might test more vigorously in order to disconfirm the pathogenic belief. And that could be a sign that the therapist is on track, but the patient really wants to disconfirm this pathogenic belief. So they're kind of, upping the ante with the testing behavior. So we sort of have our plan in place, right? That's comprised of those 5 components. And we can think about the degree to which the plan is comprehensive. Does it explain everything that I know about the patient so far and paint a coherent picture of what's going on in the patient's life? Can we try to narrow down the plan even into a sentence or two? We've been trying to do that in the group at SFPRG to try to describe the kind of core functioning of the patient in 1 or 2 sentences, and that's been very useful. And then when we're working with the plan formulation, we can continue to modify it and revise the hypotheses contained within the plan formulation by observing the patient's responses to our interventions. I do want to add another note here, and that is that patients are highly motivated from our perspective to have the therapist understand what they're trying to work on and where they're trying to go in therapy. Even coaching the therapist, albeit unconsciously, about important aspects of their plan so that the therapist can properly understand them and work with them in the way that they need. And sometimes this coaching takes the form of a direct statement, such as, despite all of these other issues, the one I'm most concerned about is my guilt regarding my mother. That's making it very clear to the therapist this is the issue that's most important to me. Or an indirect coaching statement might be something like, oh, I had a wonderful surgeon, a number of years ago who was very open with me and very warm and friendly, and it really helped me trust him. If only he was a therapist, I'd be seeing him now, for the problems that I'm having today. That would be, a form of coaching to the therapist. The patient saying, look, this is what I need from you. This is what would be corrective for me in our work together. And so coaching is often the patient's effort to get us on track and then to keep us on track. And so, that sort of concludes the formulation segment of the presentation. And keeping that formulation in mind throughout our therapies can really help us to remain focused on what the patient's trying to do, and to not stray and not get distracted by some of the sometimes contradictory or confusing information that can come up in therapy. So there's probably a lot more that I could say, but I think I should probably stop there to allow for questions. Is that right, Alex?
Yeah, thank you so much, David. That was really awesome. And thank you also, George. We have actually some questions. I know, George, you've been very kindly answering some of those questions, but we still do have some more questions for you to answer our attendees. So how about we jump right into those?
There are a couple of questions for David in particular, which I'm going to let him read and answer. And I'll just answer one of them that I said I would do live. And that is, it's one we get often, two related questions. One is about how this relates to other theoretical models. I think ACT was mentioned, logotherapy, and someone mentioned CBT. And look, there are clearly overlap. I mean, one of the things that we learned from SEPI is that there's a lot of overlap in different, there can't possibly be over 400 different schools of psychotherapy. I mean, it's just insane. That doesn't, it can't be the case. So there's clearly a lot of overlap in what is helpful and what's effective in psychotherapy and so on. So yes, of course there's overlap. There are also differences. I mean, like in CBT, just to use that as an example, one of the key differences between control mastery theory and CBT is that control mastery theory is much, much more focused on unconscious pathogenic beliefs or unconscious processes that go on. And it doesn't prescribe a particular way of treating particular groups of patients and so on. It's much more individualized, I think, than a lot of CB. And so it also focuses, like Dave was mentioning, on things like the therapist's attitudes can actually be very, very important in helping patients accomplish what they're trying to accomplish. So those are, I would say, some of the differences. I'm going to I don't know if Dave has been typing answers to his questions or if you want to say some live, Dave, but I'll let you.
Yeah, I wanted to address that question of signs that of a test being failed. That's one of the questions there that I thought we could address live. And some would include the patient becoming more closed off, becoming less expressive, patient reporting more deterioration. However, I say that with some reservation because it also depends on our knowledge of the patient. In some cases, that could be a more vigorous test. So it really depends on our overall understanding of the plan. But one thing to pay attention to when considering whether a test is passed or not is, does the patient coach us? If we did fail a test, right, often a patient will try to coach us to get us back on track. And that could be expressing some dissatisfaction with the intervention, letting us know that we were off track. They could bring in a dream. Oh, I had a dream that I was talking to this guy who really wasn't listening to me very, very clearly. And, in the dream, I wasn't able to tell him what I needed. That could be a kind of a coach from a patient who felt like we missed it.
Great. So if we can kind of also address some of the other questions here, one that's there is, what type of questions do you find helpful in identifying maladaptive beliefs?
Well, it's a, you know, it's a process, and I think what what Dave was trying to emphasize is that you can, rather than thinking of the formulation in linear terms, you should think of it more in a kind of nonlinear sort of way. You can get into pathogenic beliefs in all kinds of indirect ways. I mean, in my teaching, I usually suggest that people start out by talking about, tell me something, what brings you, how I can help you, and, you know, just do an open-ended kind of, and tell me about your life and what growing up was like. And as people describe narratives about themselves and their experiences, it's often very easy to make inferences about their particular pathogenic beliefs and so on. But sometimes, you know, things start out, sometimes something can start out with a very powerful test, and a test can tell you a great deal about the pathogenic belief. So I use an example that I like a lot from a movie called The Sessions, which was about a poet who had polio seeing a sex therapist. And the way the movie starts out, you don't know anything about the patient, nothing about the poet, but what you do, the movie he's a religious Catholic person. He goes to his priest, and he needs an attendant all the time to take care of him 24/7. And he says, and he has an attendant who's very abusive toward him. And he comes to the priest and says, "Father, do you think it would be okay if I fired an attendant that was treating me badly?" Now, someone who has to ask that question, right, you can already infer that they have a pathogenic belief. The pathogenic belief they have is that they don't deserve to be treated well. At least that would be the beginning working assumption. So sometimes you can infer all kind of pathogenic schemas and beliefs from the patient telling you about narratives, telling you about history, telling you about traumas, or sometimes, like in this example, by the patient just testing it directly.
Yeah, I have a patient who tested very early on by saying things like, "Do you think I should feel guilty for asking my ex-husband for child support?" So, I mean, you know, without even saying anything more, you can infer that this patient has some problem with asking for what she wants or what she deserves.
Great. So I'm gonna say
well, there's a question about coaching that I wanted to just comment on. Coaching is a really fascinating phenomena. We're actually working, Dave and I and others in our group are working on a new study and paper on coaching. And by the way, if anyone has any insight in terms of other models that use the concept of coaching, we'd love to hear about it, because we're trying to be very inclusive in covering the literature. But the question the person asked is it particularly important to tune in to coaching in the first session? And I think, yes, often. Now, it's a complicated thing because patients coach in different ways. There's a lot of individual differences. Some patients coach very clearly. Some patients don't coach less clearly. Some patients coach very little, if at all. So there are a lot of individual differences. But yes, generally in early sessions, whether it's the first or second or third session, that's a very, very valuable time to have your ears, or at least your third ear, open to the concept of coaching and how might the patient be coaching me around this.
So I had a patient in a first session who said to me, you know, if this is going to be one of those therapies where the therapist tells me what I ought to be doing, then I don't want to have anything to do with it. And so that was not only his way of informing me how he wanted me to work with him, but it was also informative to me in that it gave me a sense of, okay, well, that's telling me a lot about, you know, what he's experienced before and what he expects from a relationship with someone. And so it's giving some clue as to his pathogenic beliefs as well.
So I'm aware we're almost out of time, but maybe just briefly touching on the last two questions we have here. So someone, Tricia here, asks if you can discuss briefly about CMP and its use to combat severe substance abuse disorders. Any experience with that?
I'm not a substance abuse expert by any stretch. I have patients that have had, that do have and have had severe substance abuse issues. What I would say is that most therapy, this is just an opinion. I don't think there's anything, there's nothing empirical to base it on. But in my opinion, most patients with severe substance abuse need something more than just psychotherapy. The therapy alone is not going to do it. Even a therapy where the therapist is disconfirming the person's pathogenic beliefs and responding to their plan and being very attuned and so on, that will probably not be enough to help with the substance abuse portion. And I would say that most people need some kind of additional help, whether it's a 12-step program or people that don't like the religious nature of a 12-step program. They don't like the God concept. There are, I mean, in San Francisco, we have Buddhist-based 12-step programs. So I think that there's something about the community and the sense of being able to see other people who have gone through what you've gone through and come out the other end of it is very, very encouraging. And I think people need something in addition to the therapy to deal with substance abuse.
So I'm aware that we are just about out of time for today. So maybe I wanted to invite everyone, if that's okay, because I know your emails were also up there, Dave and George, if people have any extra questions that they have the liberty to reach out. And I do want to thank you for this wonderful presentation that you gave us today. I'm sure Shigeru would also say the same.
Thank you so much for all of you. I mean, it was wonderful integration of clinical and research, and I learned a lot. I mean, I always learn from you, George and David. And I just want to thank Tracy Prout, the chair of our communication and publication committee, who prepared and set it up, all of us to get together. Thank you, Tracy. And thank you, everyone.
And thank you to everyone for, thank you for having us come and present. And we appreciate all your attention and great questions and comments. So thank you very much.